So we have 21-year-old come to the office. We have irritability, aggressive. He is a star college football linebacker and training for his senior season. The patient doesn't use tobacco or alcohol. His mother had diabetes, father had basal skin cancer. Blood pressure is good, pulse is good, but a little bit it's low. Does anyone know why? Why it's low? The pulse, even the heart, the blood pressure is normal. Okay, so I will help you. If you see any athlete, any football linebacker, the normal that heart rate is lower than normal people. So it's good. It's not bad. When you see heart rate is low, don't be afraid. It's normal with the athletes. The patient is muscular and well appearing. There is no lymphadenopathy in the cervical or supraclavicular chains. Cardiopulmonary is normal. We have mild gynecomastia is present. The abdomen is soft and non-tender. Liver span is 8 centimeters. The normal between 6 and 7 centimeters. The spleen is good. We have hematocrit 58%, platelets normal, WBC normal, ESR is normal. So let's we have the keyword. We have irritability, aggressive behavior. We have football gameplay. We have gynecomastia. This is the symptoms we have. Which of the following is best single explanation for this patient's presentation? Is it anabolic steroid abuse, analogous blood transfusion, erythropoietin abuse, intensive exercise schedule, or PV, or polycythemia vera? Can anyone help us? Please. Okay. So, as we spoke before, when you solve like this question, the sorry, when you see like this question, yes, it's A, it's true. Why? When you have this question, you have to exclude. Yes, so to see the best answer. What's the meaning of autologous blood transfusion? What's the meaning of this? The meaning of this, when we have an athlete, some athletes that remove their blood and keep it away from them, and when the event is coming, they bring it back to their body. Yes, it's something not good, but some athletes is do it. When you do this, you don't have any aggressive behavior or gynecomastia, so we can exclude it. Erythropoietin abuse the same way, no aggressive behavior. Intensive exercise, the same. Polycythemia vera is the same. So we have high hematocrit because the normal is 55%, and we have gynecomastia, so it's anabolic steroid abuse. Okay. The most important thing in hematology questions that connect to another pathology. So you think aggressive behavior, maybe it's good a neurology case or something like that. So the hematology that the problem is that connect with other pathology. So be aware of hematology. It's like a trap. Please be careful with hematology. So as we spoke before, anabolic steroid abuse. This is the clinical features of androgen abuse. Types: exogenous, androgen precursors, or synthetic. Side effects: men decreased testicular function, sperm production, and gynecomastia. Women: acne, hirsutism, deep voice deepening, menstrual irregularities, and we have something cardiovascular, psychiatric, hematologic, etc. So just read the bold. Androgen abuse. Androgen is anabolic and it could have gynecomastia, mood disturbances, and aggressive behavior. And as we see, laboratory findings include erythrocytosis, hepatotoxicity, and dyslipidemia. And as let's see the choice B, as I spoke before, an autologous blood transfusion involves removing blood several weeks before competitive event and then transfusing the blood back into the athlete prior to the event. Okay, so we don't have, as we see the last line, typically it doesn't cause gynecomastia or mood change as seen in this patient. Okay, as C and D and E the same way. No gynecomastia. Okay, let's start another case. A 68-year-old man is evaluated for exertional fatigue. He used to play tennis actively, but now having a hard time finishing a set. Okay. His only other medical problem, he has hypertension, doesn't use tobacco, alcohol, illicit drugs, temperature is good, blood pressure good, pulse good. We have mild mucosal pallor, is present, no lymphadenopathy, cardiopulmonary examination is normal, there is no splenomegaly or lower extremity edema. We have the results before the laboratory results. Let's highlight the keyword fatigue, hypertension, and pallor. Okay, the pallor meaning anemia, so anemia meaning fatigue. Now, good. No malignancy signs, no lymphadenopathy, everything is good. No edema, no splenomegaly. Hemoglobin, as we spoke, it's low. MCV is good. Platelets now good. WPC is good. And even the electrolytes is good. Sodium, potassium, bicarbonate, BUN, creatinine. So no chronic renal disease. The creatinine and BUN, it's good. Calcium, a little bit elevated. When you see this numbers, the reference range will be in the exam obvious. So don't be afraid. EMREE and step 1 and step 2, you don't have to memorize a reference range. Okay? A glucose is good. So we have elevated calcium and anemia. So he put peripheral blood smear is shown here. Okay. Uh, a little bit in the last years or specific the last year, they depend a lot of X-ray and ECG and blood smear and MRI. So please be careful with these questions. Previously, we don't uh, pay attention to them when we study in the college, but please, for every exam, pay attention to everything that need pictures. So what we see here, anyone know? We have RBC, a lot of them, and one WBC. There is no schistocytes. And the last of the hematology, we know everything about blood smear. But we have something special. Can anyone tell us what is it? What is it about RBC? Mm-hmm. No one? Okay, I will speak with me. We have this type of RBC that collect with each other. This is a Rolex. It's idiom meaning that the RBC stick with each other with this picture. So let's see what is it. We have uh, total protein elevated, albumin is good, bilirubin good, alkaline phosphatase good, ALT and AST is good. So we have elevated calcium, elevated total protein, or something we call in medicine protein gap. What does mean? When we have total protein, we minus the albumin, and if it's higher than 4, this is protein gap. So we have total protein 9 and albumin 3.7. So we have elevate than 4. This is protein gap. That meaning we have a lot of protein instead of albumin in the blood. This is high calcium, albumin elevate, protein elevated, and anemia. This is something we call clonal plasma cell proliferation, or what's meaning MM, or multiple myeloma. Okay, so before we know this answer and explain it, let's see the other choices: hypocellular or and fibrotic bone marrow. This meaning myelofibrosis. Okay, the myelofibrosis is a disease that have the specific thing that splenomegaly. You link it with each other. Hypocellular and fibrotic bone marrow, meaning a lot of fiber in the bone marrow, so no RBC, so it will be anemia. And as I spoke, uh, yes, splenomegaly. And when you have hypocellular and fibrotic bone marrow, the three chains will be below the normal: hemoglobin, platelets, and leukocytes. We have here platelets and leukocyte is normal, but the hemoglobin is below the normal, so it's not good answer. Hypoplastic fat-filled marrow. This is the keyword for anemia or idiopathic anemia or aplastic anemia, meaning aplastic or hypoplastic. So the bone marrow will be fat filled. So the three chains will be below and no elevated protein in both B and C choices. Megaplastic erythroid hyperplasia, that's meaning elevated of erythroid megaplastic, so let's see it. And ring sideroplastic, we'll see the both of them. So we have multiple myeloma is a plasma cell neoplasm that often presents with constitutional symptoms, weight loss, fatigue, or bone pain. MM is should be suspected in elderly patients with hypercalcemia or normocytic anemia. As we spoke, the MCV between 80 to 100, it's normocytic anemia, and renal insufficiency and a protein gap as in our patients. So what the meaning of protein gap? Difference between total protein and albumin higher than 4. Okay, so there is a non-albumin protein in the serum, and we have something called M spike, and diagnosis is bone marrow biopsy, and this patient's peripheral blood smear. This is the keyword for the disease. It's Rolex formation, stacking of red blood cells like coins, finding with elevated serum protein, meaning the RBC stick with each other. We spoke about B and C. Let's see choice D. Megaplastic erythroid hyperplasia, meaning megaplastic anemia by caused vitamin B12 or folate deficiency. Megaplastic anemia, meaning elevated MCV and no protein gap or hypocalcemia. Ring sideroblast, this is this typically presents with microcytic anemia and hemoglobin below 7, and no protein gap or hypercalcemia as we see in these patients. So everything is good. Do you need any something to repeat or clear it? Please let me know. Send a message. Okay, so we are good. Please send emoji. something like that. Okay, it's clear. Thank you. Thank you. Okay. You see, this session is good so far. Any feedback? Okay, just put like, yeah, thank you, Dr. Tala, thank you too. Okay, let's move to another question. Item 4 of 40. A 43-year-old woman comes to the emergency department with abdominal pain and dark urine. Physical examination shows right upper quadrant tenderness without guarding or rebound. We have the laboratory results. Hemoglobin is low, platelets a little bit low, total bilirubin is high, LDH is high, haptoglobin is low. What is haptoglobin? We will talk about it later. But further workup, including MRI of the abdomen, shows hepatic vein thrombosis. So, we have abdominal pain and dark urine. This is a hallmark of, anyone tell me? Abdominal pain and dark urine. Or let's talk about dark urine. This is RBC destroyed. Okay? Hemolysis. When you see dark urine, please remember this is a hemolysis. Okay? And the sign of hemoglobin is 8.9. That's meaning there is a lot of RBC has destroyed. So we have MRI, hepatic vein thrombosis. What is the most likely diagnosis? What is the link between the three things? Abdominal pain, dark urine, and hepatic vein thrombosis? Is it acute intermittent porphyria, plastic anemia, G6PD, hereditary spherocytosis, or paroxysmal nocturnal hemoglobinuria? So even if you are not study hematology yet, so I think you have a little bit of information. So let's, as I spoke before, let's exclude. Please, when you see like this question, please depend on exclude, not select the right answer. So anyone can exclude anything, please. Your voice or message. Yes. So let's see about G6PD deficiency. Why we should exclude it? I will tell you two reasons that G6PD deficiency is wrong. One, we have an old patient, and G6PD happened in children with the first time with antibiotic or an stress that cause hemolysis. The second thing that is woman. And remember, G6PD is X-linked recessive. So it's rare to happen in women. So let's remove it. What about a plastic anemia? When you see a plastic anemia, right, the hemoglobin is low, but and platelet is low, but the total bilirubin is high. So it's hemolysis, not a plastic anemia. So remove it. Acute intermittent porphyria, yes, it's dark urine, but you have you need a rash. Okay, it's true that cause dark urine and abdominal pain, but the purpuric rash is evident in all cases of acute intermittent porphyria, or instead of rash, you may have and joints pain or arthritis. Okay, so A, B, C is wrong. What about D, hereditary spherocytosis? Yes, it causes hemolysis and causes abdominal pain, but in hereditary spherocytosis, there is no hepatic vein thrombosis. Let's go back to the MRI of the abdomen. In hereditary spherocytosis, it causes that the shape of RBC is spherocytes, okay, and is the it's normal. The type of hemoglobin is good, but the shape of RBC is spherocytes instead of the disc. So it's wrong because it's happened previously, so not in 43, not hereditary. It's true. When you see hereditary, it's meaning that in the genes, so it's happened before that 43. So it's paroxysmal nocturnal hemoglobinuria. Yes, you may not heard of it before or forget it. Let's memorize it together. This is PNH or paroxysmal nocturnal hemoglobinuria. Let's see, this table is so important. Please memorize it and keep it with you at any time you want to do the exam. So clinical manifestations: hemolysis, so meaning fatigue; cytopenias, so no hematopoiesis; and the most important things that we should highlight it, that venous thrombosis, meaning intra-abdominal or cerebral veins that have thrombosis. Okay, so what we should do, we or work up what we can see. We see complete blood count, hypoplastic or aplastic, and thrombocytopenia and leukopenia. The three chains may be below the normal in PNH. Elevated LDH and low haptoglobin. So let's link low haptoglobin meaning hemolysis. Please memorize it as much as you can. Low haptoglobin meaning hemolysis. We have indirect hyperbilirubinemia, and urinalysis we see hemoglobinuria. Flow cytometry, and this is the gold standard for diagnose PNH, meaning absence of CD55 and CD59. We will see this later. Treatment, iron and folate supplementation because the hemolysis. So we need to give the patient iron folate to synthesize or to make a new RBC. There is a monoclonal antibody, no eicosapent. Okay, let's see this the disease. This is PNH. PNH is autoimmune hemolytic disorders. We have intravascular and extravascular hemolysis. In the next sessions, we will talk a lot of them. And we have hemoglobinuria. The disease is due to an acquired genetic defect that results in lack of glucose phosphatidyl inositol anchor. Oh, what this is? This is a connects proteins CD55 and CD59 on the cell surface. I will tell you a thing that's easy on you. You see this CD55 or 59 that save the cell or save the RBC from complement attack. Okay, so without CD55, without CD59, the complement will attack RBC. Okay, so we have hemolysis. So uh, the normal state, we have CD55 and 59. Okay, on average, so we have it could happen in fourth decade because we have three things: hemolysis, so hemoglobinuria; cytopenias, so we have fatigue; and hypercoagulable state, which meaning portal vein thrombosis, and that lead to acute abdominal pain. So we have elevated bilirubin. Sorry, these patients, we have low haptoglobin elevated bilirubin, and elevated LDH. Okay, so this is hemolysis. Please be careful with intravascular or extravascular. We'll talk about them in the next lecture. So to confirm the diagnosis, we need to do flow cytometry tests are used to confirm diagnosis by assessing the absence of the CD55 and CD59. Okay, so let's back to the choices. Acute intermittent porphyria. So it could happen with abdominal pain and dark urine, but there is no hematologic abnormalities and no thromboembolism. Okay, so the dark urine is not from the blood, it's from the pigmented urine because of porphyrin. Okay, so when the patient have acute intermittent porphyria, it's true that the dark urine, but it's not hemolysis or it's not blood. Okay, elevated LDH, it's make hemolytic anemia much more likely than aplastic anemia. G6PD, we spoke about it. There is no thrombosis and hereditary spherocytosis. Some symptoms before it could happen in before 43, but as we spoke, there is no venous thrombosis. So hemolytic and thrombosis, please be careful with PNH. Let's see the three. Let's repeat them. If you have PNH, you have hemolysis, cytopenias, hypercoagulable states, and the diagnosis is flow cytometry, the absence of CD55 and 59, and the pathology, that meaning the complement proteins attack the RBC. Okay, everything is good now. We okay. Please tell me in the message, is everything is good? The voice is good. The tone is good. Should I be faster or slower? Yep, perfect. Thank you, thank you, thank you. I appreciate your help. Yes, I'm very happy with this positive feedback. So let's get back to the hematology. So we have 29-year-old man comes to emergency department following a motor vehicle collision. I hate these questions. Please be careful with emergency. In the emergency, you must be careful of any choice and any sentence in the case. In this case, I will be slower than before because it's had a lot of distraction. So let's be careful together. So we have a motor vehicle collision. The patient is alert and oriented. Trauma evaluation shows an unstable pelvis with a pelvic fractures confirmed by imaging. Okay, so the neurology state is good, alert, orientated, but we have pelvic fracture. Okay, he received multiple pulses of intravenous fluids and he started on packed RBC transfusion. Be careful. The first thing to give fluids to the patient is not blood. Before we bring him blood, we should give him some fluid before or pulses of intravenous fluids before we give him blood. A few minutes after the transfusion starts, the patient develops shortness of breath, episode of non-bloody emesis, and no chest or back pain. Temperature is good, but blood pressure is low, and pulse is elevated, and respiration is elevated, and pulse oximetry is below normal. It's 86% on 100% oxygen provided via non-rebreathable mask. Okay. Okay. So there's a low oxygen, low blood pressure, and elevated in pulse. The patient answer questions in short phrases, and lung examination. Decreased breath sounds bilateral. Pulses are weak. Urinalysis is good. what is the most likely cause of this patient's respiratory distress? Why I mention that the emergency question is important? Because it's assess you that you are good doctor or not, safe doctor or not. Because the good doctor think quickly. So in your exam or in your test, when you give you this question, you they want to assess you if you are in emergency room and what to do, what do you think. So they pay attention to this question, and you should pay attention to this question. Okay, let's see the answers. We have anaphylactic reaction, aspiration pneumonitis, fat embolism, hemolytic reaction from ABO, and reaction from cytokines in transfused blood, volume overload. Okay, let's think deeply. Before we start, we have not, as I mentioned before, not choose the right answer. Eliminate the wrong answer. So, aspiration pneumonitis, when you see it, there is no low blood pressure. Okay, so we have low blood pressure. Okay, so no aspiration pneumonitis. Just this point, eliminate aspiration. Fat embolism, which meaning after the long bone, please focus on my words, after a long bone or any big bone in the body broken, it will be fat embolism. Go and it could happen like PE or pulmonary embolism. So the low saturation, okay, and it's stress and it's hard case. But in this case, it could happen, but no, or it could have make the blood pressure is low, but not like this, not 88 and 40. Okay, and even the good keyword for this is wrong that we have in the four fifth. Sorry, which line? The weak. Okay, where is the weak pulse? My line. Can't see it. Okay. Okay, the 6 lines called pulses are weak. This is pulses are weak and low blood pressure. This is anaphylactic reaction. Please, when you see blood pressure is low, pulses are weak, please, and after blood, please, this is anaphylactic reaction. But why it's not hemolytic reaction? Because when you see hemolytic reaction, uh, it's rarely happened nowadays. So it could happen, but when you see it, the patient must have jaundice or dark urine. Okay, when you mention urinalysis is normal, just to exclude hemolytic reaction. So as we spoke in the previous question, when you see hemolytic reaction, regardless of the cause, you see dark urine or the urine is not normal. Okay, reaction from cytokines in transfused blood. Uh, it's similar to anaphylactic reaction, but the anaphylactic reaction is more danger than reaction from cytokines. Okay, we'll see the difference between them in the next table. Volume overload will be the blood pressure is higher than normal, not below the normal. Okay, so I mentioned the must highlighted, or sorry, the must highlighted information in to remove the wrong answers. So, transfusion reactions associated with hypotension, we have anaphylaxis and transfusion-related acute lung injury. So let's talk about each of them. Anaphylaxis happens seconds to minutes, like our patients. This is because recipient anti-IgA antibodies, the antibody from the recipient uh, attack, uh, sorry, the antibodies from the donor affect the recipient, okay, and make the patient has shock, angioedema, urticaria, and respiratory distress. But please, if you don't see angioedema and urticaria, please don't exclude anaphylaxis. Not every anaphylaxis happened with urticaria and angioedema. Okay, it's right that clinical features have angioedema and urticaria, but in lifetime or in the clinical life, you shouldn't see it every time. Transfusion-related acute lung injury. This is happen minutes to hours. It's donor anti-leukocyte antibodies. It's true, but not to anti-IgA. This is the pathology, but we need to respiratory distress and bilateral pulmonary infiltrates. The time is important, minutes to hours. Our patient, a few minutes after transfusion starts. Okay, so it's happened rapidly. Acute hemolysis, as we spoke, flank pain, hemoglobinuria. There's a problem, hemoglobinuria, and we have the IC, bacterial sepsis. You have fever, chills, septic shock. So the last two choices, acute hemolysis, or sorry, the disease, bacterial sepsis and acute hemolysis, it could happen with DIC. Okay, so it's good. Do you need any help with this question before we go to the next one? Mhm. Everything is good? Yes, all good. Thank you. Okay, okay. So let's move to another one. A 72-year-old man comes to the office due to severe fatigue. He says that 5 months ago he was able to climb 4 flights of stairs without shortness of breath, but now he has to rest after 2 flights. My friend, this is normal. This is 72-year-old, so no problem until now. His appetite has decreased, but he has not had any abdominal discomfort or black stool. So when you see no black stool, so meaning not GI blood coming from. When you have black stool, meaning that, or melena, this is bleed in the gastroenterite. Physical examination reveals firm, enlarged cervical, inguinal, and supraclavicular lymph node. When you see supraclavicular lymph nodes, please tell the patients that this prognosis is not good. Please, when you see supraclavicular lymph node, this is a problem. Okay? Please, this is a malignant sign. Please memorize it. Supraclavicular lymph node or Fairchow node, this is not good at all. A soft 2 to 6 grade systolic murmur, 2 from 6 grade systolic murmur along the left sternal border, it's not so important. It's like distraction in this question. Abdomen is soft, non-tender, liver span 10. So it's higher than normal. Spleen is 4 below the left costal margin, so he has hepatosplenomegaly. His blood 7, which is the most likely cause of this patient's anemia, iron deficiency, folate, copolamine, or meaning B12, G6PD, red blood cell membrane defect like PNH, remember it, CD55 and CD59, hemoglobinopathy like thalassemia. Okay, bone marrow infiltration, intravascular hemolysis. There's no hemolysis sign. Okay, no dark urine. Not uh, happened acutely. Erythropoietin deficiency or bone marrow aplasia. Just we see supraclavicular lymph node, so it's bad prognosis. This is bone marrow infiltration. Regardless of any disease, when you see supraclavicular lymph nodes, this is bad prognosis. Okay, so the causes of anemia, we can divide it into three categories: decreased RBC production, like bone marrow infiltration, or increased RBC destruction, like hemolysis, or blood loss, like the black stool we spoke before. So the patient, this vignette, has several signs and symptoms suggestive of lymphoproliferative disorder, most likely lymphoma, or so we have lymphadenopathy, splenomegaly, and constitutional symptoms fatigue. The anemia, leukemia or lymphoma. So you mean there is something in bone marrow. A and B and C, iron, folate, cobalamin, not associated with lymphadenopathy or splenomegaly. So the deficiency not meaning splenomegaly. G6PD and hereditary spherocytosis and sickle cell and thalassemia not associated with lymphadenopathy. Hemolysis, we will speak later. Please be patient with me. Erythropoietin deficiency meaning in renal failure. Our patient hasn't it. Bone marrow aplasia or aplastic anemia, we don't see splenomegaly. Okay, so it's alternate diagnosis. So it's easy question, but need a tricky. You must memorize it. Okay, and this question also has a trick just to memorize it. Okay, let's see it. A 47-year-old woman with a long-standing history of SLE. Okay, the patient has SLE. Come to the office due to a month worsening fatigue and low-grade fever and lost 4.6 kilogram. No joint pain or cough, dyspnea, chest pain. No. Let's see about the problem. It's not from chest. No dyspnea, no cough, etc. Other medical conditions include hypertension, hypothyroidism, anemia of chronic disease. The patient take the drug for SLE and glucosteroid for acute symptom flares. The temperature is good, blood pressure good, everything is good, vital is good. No scalar icterus, meaning jaundice or elevated bilirubin or yellow eyes. No scalar, no yellow eyes, meaning no hemolysis. So the anemia is not from hemolysis. No oral ulcers, no skin rash. There is a large axillary and cervical lymph nodes. The lungs are clear on and heart sound are normal. Abdomen is good. No organopathy. There's no edema. No joint tenderness. So it's not SLE flares. Okay. When you see no edema, no joint tenderness, no problem, no rash. So it's not SLE. Just we have. Let's see the lab, but we have fatigue. Okay, this is the keyword in the question. SLE and fatigue, everything is good, no flares. Hemoglobin below the normal, platelets good, leukocytes good, BUN good, creatinine good, but we have elevated LDH. Okay, and TSH is good. So what most likely cause of this patient current condition? Is this ALL, infectious mononucleosis, medication adverse effect, non-Hodgkin lymphoma, or tuberculosis infection? So let's, okay. So as we spoke before, when you see like this question, please exclude, okay? So tuberculosis infection, please, no fever, no tuberculosis, okay? But we have low grade fevers, and we see no cough, no dyspnea, no chest pain, so no TB, okay? Another thing about acute lymphocytic leukemia, ALL. When you see ALL, it could happen after SLE, but there is ALL, meaning that is acute. So the problem is acute. Okay, could happen with month worsening fatigue, but now let's talk about the most common after SLE. There is most common than acute ILL. This is non-Hodgkin lymphoma. Okay, about ILL, it could happen with splenomegaly, but no adenopathy. Okay, it's not happen ILL or rarely happen with cervical axillary lymph nodes enlarged. Okay, it's a little bit tricky. So the true choice is non-Hodgkin lymphoma. We will see why we exclude another choices. So the I want to link the SLE. Okay, when you have SLE, has fatigue, low-grade fevers, lymphadenopathy. It could happen with acute SLE flares, but we have another thing with flare. You need joint symptoms, rash, oral ulcer. So, as I spoke, there is no rash or oral ulcer or joint symptoms, so it's not SLE flare. Okay? So, when you have furthermore patients with well-controlled SLE, rarely have weight loss and elevated LDH. But it could happen with SLE, so the patient has non-Hodgkin lymphoma. Okay? The trick in this paragraph, patients with chronic autoimmune disease, SLE, Sjogren, are at increased risk for non-Hodgkin lymphoma. Please pay attention to this. Non-Hodgkin lymphoma presents with progressive painless lymphadenopathy and B symptoms, which is white loss, fever, night sweats, and elevated LDH. Okay, please memorize this. Chronic autoimmune disease, SLE or Sjogren, with weight loss, so the patient has NHL or non-Hodgkin lymphoma. Okay, this is the choices. Okay. Okay, it could happen, or sorry, although the risk of most lymphoproliferative disorders elevated in autoimmune disease like ILL, but ILL happen in children, not in adults. It could happen with bone pain, okay, and RBC significant neutropenia and thrombocytopenia, okay. In non-Hodgkin lymphoma, you don't see severe neutropenia, okay? But in ILL, severe neutropenia and severe thrombocytopenia, okay? Please. Infectious mononucleosis, this is infectious disease, cause peripheral lymphadenopathy, fatigue, low-grade fever, but could happen with throat or pharyngitis, okay? Furthermore, no weight loss or elevated in LDH. Certain medication like phentoin, it could happen with painless peripheral lymphadenopathy with or without signs of serum sickness, no rash, fever, arthralgia, etc. But hydroxychloroquine doesn't typically cause this manifestation. No peripheral lymphadenopathy. Okay? Tuberculosis, I spoke about it. So everything is good. Any help? We have the last 10 minutes and good. But to check up all the hematology or to be good with hematology, we need 3 sessions, okay? Today and the next Thursday and the next Monday, okay? and we will end the hematology. Okay, so far, any concerns? Are you bored? Okay. Oh, okay. So another trick and another something is very important. And to be a good doctor, you need to know this answer. Okay. 55-year-old male present with face and arm swelling that he says is worst when he wakes in the morning. Okay. He also notes a 10-pound unintentional weight loss over the past 3 months. Please focus. When you see weight loss or unintentional weight loss, please think with malignancy. Please. It's like the supraclavicular nodes. This is something you shouldn't forget. Okay, so now we have new onset exertional dyspnea. His past medical history is significant for hypertension, for which he takes hydrochlorothiazide. He has smoked cigarettes for the past 40 years and drinks alcohol occasionally. So we have a risk factor, smoke. On physical examination, he is a febrile and his vital signs are good. His face is plethoric and dark appearing, so his face is red. The veins on the anterior chest wall appear engorged. His abdomen is soft, non-tender, non-distended, and there is no organomegaly. The lower extremities are non-edematous. What is the most appropriate next step in the management of this patient? Okay, let's talk about the keywords. Swelling, face and arm swelling in the morning, intentional weight loss or malignancy, smoked cigarettes, face red and dark appearing, abdominal is good, no organomegaly, non-edematous lower extremities. So we have the swelling just in the face and arm, not in the lower extremities, not on the day or not on the night. So the most appropriate next step, echocardiogram, Doppler ultrasound, chest x-ray, urine 24-hour, or serum albumin level. Help me. A, B, C, D, E. Right? Even if you are wrong. C. Yes, that's true. When you see like this question, please choose chest x-ray because the first thing it's easy and quickly and more emergency. Okay? Echocardiogram, if when you ask an investigation, please focus why and ask yourself why I should order this investigate. Okay, so this is just x-ray. Let's see why. Okay, this patient's signs and symptoms consist with superior vena cava syndrome. Please, a condition where obstruction of SBC, meaning the venous from the head, neck, and arms to the heart. So when we have this disorder or something, obstruction of SBC, meaning that we have swelling head, neck, arms, the upper side of the body, not the lower. So we maybe have dyspnea, venous congestion, swelling of the head, neck, and arm. Malignancy is the most common cause of obstruction, meaning lung cancer or non-Hodgkin lymphoma. Okay, so we should take the choice C, chest X-ray can identify the cause of SVC syndrome. higher than 80, 100% of cases. Okay. Echocardio, it's not part of workup for SVC. Echocardiography maybe could happen, or maybe we do it in suspected cardiac tamponade when there are a lot of fluid around the heart. This is come with big stride, jugular venous distension, stent, heart sounds, and hypotension. We will see it when we talk about cardiology. Okay. Unexplained unilateral arm swelling. Maybe we should do Doppler for DVT. But the face, bilateral arms, so this is meaning of SVC, not and peripheral VN. Okay, so we don't do Doppler for DVT. D&E, this is 24. It's for nephrotic syndrome when we have generalized edema. Okay, and albumin for generalized edema. This condition can cause generalized edema, but not edema isolated to the upper half of the body. Okay, everything is good. Okay, yes. Let's move to the last question. I know that's hard on you, but please let's end this question. A 65-year-old man is brought to the emergency department due to chest pain. The patient has had fatigue, retrosternal heaviness, and non-productive cough for weeks. Okay? Today he developed severe chest pain at a retirement party after drinking a beer. The patient has no chronic medical conditions and takes no medications. He doesn't smoke but drinks alcohol socially. Temperature is good, blood pressure good, pulse good. Peripheral examination, clear lungs, normal heart sound. ECG, sinus rhythm, no problems. Chest X-ray shows large anterior mediastinal mass displacing the trachea. Please, so let's highlight the important chest pain, had fatigue, retrosternal heaviness, non-productive cough. Okay, everything is normal. Just we have a large anterior mass. Hemoglobin is low, so we have fatigue. MCV is good, platelets good, leukocytes good. LDH elevate. Serum troponin is normal, so uh, no heart infarction. Okay. So no problem with the heart. The problem is hematological. So which of the following is most likely diagnosis for the patient? Is this germ cell tumor, histoplasmosis, Hodgkin lymphoma, sarcoidosis, thymoma? Okay, thymoma happened with something called MJ, okay, myasthenia gravis, which meaning the muscle weakness. Okay, our patient haven't this thymoma. Sarcoidosis happen with inflammation of the lungs. Okay, it's more chronic than 1 month. Okay, or several weeks. Sorry, and no elevated LDH in sarcoidosis. Hodgkin lymphoma. This is a true germ cell tumor. You will have a sexual appearance like gynecomastia or hair, etc. So there is hormonal problems. Histoplasmosis need a rash. Histoplasmosis rarely common without rash. So the anterior mass, this is Hodgkin lymphoma. So let's memorize it. Hodgkin lymphoma by model peak incidence 15 to 35 and upper than 60. Association with EBV in the immunosuppressed, painless lymphadenopathy, mediastinal mass, and B symptoms and pruritus. Okay, our patient, no pruritus, no problem. We need lymph node biopsy. Okay, this just to the read the bold. this mediastinal mass, meaning Hodgkin lymphoma, that must affects 15 to 35 and below 60, develops in a single lymph node and spreads to contiguous nodes via the lymphocyte and thoracic ducts. Let's move to mediastinal lymphadenopathy, cough, and retrosternal chest pain. Okay, so let's go to the no, eosinophilia and elevated LDH. Okay, the other choices are away or so far from this case. Okay, I think it's good. Okay, we will stop here about this case. Everything is good.